Len's out of town in Hawaii, and then we all feel bad for him. But yeah, today we have Sarah talking about food component testing. So, Sarah, she had a dog she had to walk.
Yeah, I'm watching my friend's dog, and the dog would not pee this morning. So I was trying to get it to go to the bathroom before I came in to work. So that was my morning. All right.
Should have brought him with you.
So, I know, she's really cute. All right, so I'm going to talk a little bit about food allergy component testing and whether we should or should not test. So just a little bit of background. So food allergy is defined as an adverse health effect arising from a specific immune response that occurs reproducibly, which is kind of a key word, on exposure to a given food. So these are all kind of from the FAIR website. So it says that the prevalence of food allergy has increased about 50% over the last decade in the US. The prevalence of peanut and tree nut allergy in kids has about tripled over the last 10 years. There's about 32 million Americans that have food allergies, and about 1 in 13, or about 8% of kids have food allergies. Again, some of these are kind of from self-reporting, so you kind of have to take that with a caveat when they actually do then true OFCs to see if people react. The numbers tend to be a little bit lower. But then caring for kids with food allergies costs nearly $25 billion. There's about 200,000 people each year that require ED care for allergic reactions, and there's about less than 100 fatalities per year, most during kind of that second to fourth decades of life. And then if you have asthma, you're at increased risk for a severe or fatal food reaction. And then, so the mechanism, there's kind of a couple of different hypotheses of kind of why it occurs. This is all from, there was a great review by Scott Seghezzo, I think that's how you say his last name, at Sinai. And so there's kind of a couple leading hypotheses. There's microbial exposure, so whether this decreased microbial exposure hinders your immunoregulatory responses, so kind of looking at whether it's like that's kind of looking at probiotics, and if we add probiotics, or is it C-sections, or kind of is it this like increased microbiota that gives you, kind of pushes you away from allergy. Allergen avoidance, so that was predicated on the concept that early life avoidance would prevent sensitization. I think we've kind of started to steer away from that with the LEAP trials. There's the dual allergen exposure, which a lot of people are kind of pushing towards right now, whether that's you have eczema or something that you're sensitized through your skin, and then that overall overrides the tolerizing oral exposure. And then there's some nutritional modulation, various dietary factors, so people are looking at vitamin D and some other kind of nutritional components potentially if there's steer you in one direction or another. Regardless, so this is mostly for the fellows because this is what I studied during all of boards, and literally there's like 20 questions on this. So during allergic sensitization, your food allergens are presented to the T cells, and you ultimately get a Th-skewed response that commits B cells to IgE production, and allergen-specific IgE will then bind to the high-affinity IgE receptors, which is the Fc epsilon HER1, which is on the mast cells and basophils. And ultimately, then on subsequent re-exposure, you'll get these allergens that'll cross-link to the receptor-bound IgE, that'll activate the mast cells, that'll activate the basophils, it'll release preformed mediators, and you'll get then de novo synthesis of leukotrienes and cytokines, and then that leads to your allergic response. And so the diagnosis, so there's over 170 foods that have been identified. The most common are the peanut, tree nuts, fish, shellfish, milk, egg, wheat, soy, and seeds. History remains the most important aspect of diagnosis. So in general, you probably, with all the testing that we'll talk about later, that's kind of on your selected individuals that you've decided to do kind of based on history. And then your oral food challenge, technically the double-blind placebo-controlled food challenge, is kind of the gold standard for diagnosing a food allergy, though in clinic we usually just do open label challenges. And so looking a little bit at diagnostics, so there's various tests that are used to diagnose the IgE-mediated food allergy. And so you have your skin prick test, which, food partner. So you have the, maybe? No? I clicked on it. Maybe I clicked on pen. There. So there's the skin test, and that measures the response of skin mast cells to the allergen. You have the basophil activation test, which I feel like I haven't used that much clinically, but it's starting to become more popular now. And it measures the response of circulating basophils to the allergen. Then you have your IgE test, which measure the concentration of circulating IgE, whether that's your total IgE or your specific IgE to allergen extracts or to individual allergen components. And then you have the total IgE and the allergen-specific IgG4, and those can be used to calculate ratios with specific, there's your IgG4, to allergen-specific IgE, and that's used more so in clinical trials. So I know for the immune studies, they kind of followed the IgG4 and they kind of watched how that shifted if you were shifting more into tolerance, and how that ratio changed with your IgE. So kind of the two main ones that we use are skin prick testing and serum Ige testing. So skin prick testing has a relatively high negative predictive value. The sensitivity and the specificity, that's kind of the general one that was listed in the practice parameters, but it can vary by food. But interestingly, individual results can actually vary depending on the skin prick device that's used and the way in which the wheel is measured. So there was a kind of paper that looked at just 1 milligram per ml histamine and using various devices, whether that was single prick or multi-prick. And so the wheels varied from 3 to 6.8 millimeters. And then if you use stronger histamine, 6 milligrams per ml, again, that varied from 4.8 to 8.4 just of the histamine control. So that's just something to keep in mind, when you also look at, what the sizes and cutoffs are for some of these values. And then you have your serum specific Ige, and so that's fluorescent labeled antibody assays that are used to detect the presence of circulating Ige antibodies to suspected foods. It's useful in situations maybe where your skin prick test is negative but you have a high clinical suspicion, or when you can't do skin prick testing because there's really bad skin disease, dermatographism, or the patient just keeps on taking their antihistamine. And then that kind of can determine sensitization. And then this is per the 2014 updated practice parameters, which I feel like, that was 5 years ago, and a lot of stuff has changed since then. And most, things that'll kind of go moving forward, they'll kind of report both. But technically for the practice parameters, it says alone, it cannot be considered diagnostic of food allergy. And then there is variability among the different immunocap assays. So if you use Fadia versus Siemens versus HiCor, you'll get different, the values are not consistent throughout. And so this is again from the review by Sara, and so it's kind of just giving you general sensitivity and specificity to the different various foods, both in skin prick testing as well as specific Ige testing. And then this is kind of looking at general cutoffs that they had found for egg, for milk, and for peanut, depending on kind of what the percent of reaction would be. What's interesting is that obviously it changes by age, so depending on what your age is, and then this peanut one is dependent whether or not you have or haven't eaten, so you have a higher value if you have not eaten ingested peanut. And so, these tests should ultimately be viewed kind of solely as positive or negative. And then, with the increased values of the skin prick test or the specific Ige, there's an increasing chance of a clinical reaction. But then the correlation of the tests, it's very variable by the center, by the age, by the disease. And so kind of some of the component stuff that I'll talk about in a little bit, the results are very variable depending on what population you're looking at. And then ultimately you follow these over time to monitor either persistence or resolution. So component-related diagnostics, so that's looking at allergen-specific Ige to component allergens using single allergenic molecules instead of kind of the crude extract. And the thought is that this will allow for more precise profiling of the allergen-specific Ige repertoire. And so your components can either be classified as belonging to different protein families based on their structure and their function, and then you'll have Ige antibodies that are directed at these proteins. And so if they're in the same family, then a lot of times you can get cross-reactivity. And so your different protein families can include your storage proteins, the PR10 profilins, lipid transfer proteins, cross-reactive carbohydrates, calcium-binding proteins, serum albumins, parvalbumins, tropomycins, and lipopalins. And there's kind of some pretty well-described cross-reactivity among foods and pollens. And so you may be observing a positive test that's related, to that food, but it might not actually have any clinical implications. So kind of the two most common ones are Birch. So you can have a lot of positive skin tests to foods like peanut, almond, hazelnut, a lot of fruits and vegetables because you're Birch allergic. And same with cockroach and dust mite. You can get positive tests to crustacean, shellfish. So going into kind of some of the different foods. So milk, it affects about 2 to 3% of young children with about 50% resolution by age 5 to 10. So your major proteins are casein, beta-lactoglobulin, and alpha-lactoglobulin. Kind of the studies have shown that the casein, that's what's resistant to extensive heating. And so higher levels of the casein and the beta-lactoglobulin are associated with reacting to heated milk, and there's a decreased likelihood that you'll develop tolerance, and then you're at a higher risk of systemic reactions. And so there's been a couple of different studies that have looked at, are there thresholds for casein that if you have a low casein, that'll allow you to tolerate baked milk? And we know that through some more recent trials that if you are able to tolerate baked milk, that can hopefully accelerate your tolerance of unheated milk products. And so potentially screening for those people that can tolerate the baked milk, you'll kind of push them more in that tolerance direction potentially sooner. For egg, it's the second most common allergy in children. There's about 50% resolution by age 2 to 9. So your major proteins include ovomucoid, ovalbumin, overtransferrin, lysozyme, and conalbumin. And so your ovomucoid, which is GAL-D1, that's the dominant allergen. And again, it's stable against heat and digestion by proteases. Overall, it represents a pretty small percentage of total egg white protein, but that's kind of the one that's been the most studied in determining tolerance to baked egg. And again, high levels of this are associated with persistent egg allergy and a decreased probability of cooked or heated egg tolerance. And kind of same thing as before, they know that, if you're doing baked egg products, that again will kind of push you more towards tolerance if you're able to do that kind of consistently. So for peanut sensitization overall is quite common, but the clinical allergy itself is more rare. And so there's a lot of different proteins for peanut. There's the main one that's really been studied is ARA-H2 as kind of an overall better predictor of clinical reactivity versus your total peanut total IgE. However, ARA-H1, 3, and 6 have also been associated with severe reactions. So you have your ARA-H2, which is your major peanut protein. It's a seed storage protein, and again, it's important predictor of clinical reactivity. ARA-H5 is associated with both grass and birch, and so that one tends to be more of an oral allergy type syndrome. And then same with ARA-H8, there's again cross-reactivity with that B1, which is birch. And then your ARA-H9 is another lipid transfer protein. That one's associated with peach, and it has been correlated to mild to severe symptoms in Mediterranean patients. And this is from one of the review papers, and it was kind of saying, what might push you more towards in one direction or another. And so they were saying, factors potentially for peanut in and of itself that would make it less likely to be informative to get those components would maybe be if you have a convincing clinical reaction, if they just reacted, regardless of what your testing shows, you're probably going to tell them to avoid it, especially if it's a very convincing history. If they have a remote significant clinical reaction and their peanut IgE is still pretty elevated, if even without a reaction, if your peanut IgE is super high or it's super low, then the components might not provide you anything else. If you don't have birch sensitization or if it's a younger child, it might be more likely to be informative if you kind of have these mild reactions or no reaction history, a remote clinical reaction, but then you've developed birch sensitization over time. Your IgE that's kind of in that middle range or kind of for older patients. And then looking at tree nuts, so there's this really interesting nutcracker study that was done out of Israel. And so they were looking, again, all of these trials are pretty small. And so there was only a total of 83 patients, but they were, first of all, like the majority of patients were sensitized to 5 to 6 tree nuts, but then they actually oral challenged all of them. And over 50% were only allergic to 1 to 2. Kind of like we see in clinical practice, the highest rate of allergy with sensitization were kind of the walnut and the cashew. And then the rate of co-allergy for most tree nuts was less than 30%. And then they kind of found, about 2/3 of walnut cashew allergic patients were also allergic to pecan and pistachio. But conversely, if you were allergic to pecan or pistachio, then all of them were allergic to cashew and walnut. And so hazelnut is one of the most common tree nut. It's the most common tree nut allergy in Europe. There's quite a few major proteins that are in the core A class. And so core A1 is it's a heat labile protein, and so again, it's homologous to that B1. Then core 8, 9, and 14 are associated with more severe symptoms. So the 9 and 14 are seed storage proteins, and then 8 is a lipid transfer protein. And there was a recent meta-analysis that they did in pediatric allergy-immunology, and they only included studies where there was follow-up confirmatory food challenges, but they found that core 9 and 14 had increased diagnostic specificity in assessing hazelnut allergy in children. And then when you combined it with the use of hazelnut extract and storage, the storage proteins improved your overall diagnostic value. And they've overall kind of demonstrated a greater specificity than the traditional skin prick testing and specific IgE to the hazelnut extract. And it kind of helps you differentiate whether the patients are more so just Birch pollen sensitized, so maybe you just have some mild oral symptoms or no clinical reactivity versus those with a severe allergic reaction. And then there's less, I couldn't find as many papers. There's a handful on kind of the other tree nuts. So cashew, it's one of the most common tree nut allergies in the US, along with walnut. The major protein is ANA03. It's another seed storage protein, and that again is associated with the cashew pistachio allergy. Walnut, the proteins are jugar1 and jugar3. Brazil nut, berry 1, and then almond, what was interesting, there's no CDR available, but there was a recent study in the Annals that looked at 400 patients that were sensitized to almond, and they OFC'd all of them, and the probability of passing was about 95%, even if your specific IgE was up to 10 and your skin prick test was up to 5. So something important to think about clinically for almond. For soy, it's the most commonly reported allergen, and most of the soy allergens will become tolerant over time, so about 45% will resolve by age 6. It's hard to diagnose because of the high false positive rate. And again, you're looking at the major proteins are GlyM1, and so GlyM4, or GlyMs. So GlyM4 is your Birch pollen homologue, similar to BET-V1. Ultimately, the major studies have been looking at GlyM8, which is a 2S, it's another seed storage protein, and it's a 3-dimensional structure, and it has high stability in the GI tract and in heat processing. And they've found that it's as sensitive as skin prick testing and other components, but it's more specific, again, for clinical reactivity. But again, that varied, so a lot of the soy stuff is out of Japan, and so these were pretty indicative in Japanese children, but then when they tried to kind of repeat it in Europe, there was less so that they were able to they didn't find as many differences. For shrimp, the prevalence is 1.3 to 5.2% in children to adults, depending on your country and your dietary habits. Your major proteins are PEN-A1 and LIPV1, and those are both tropomycins, and those are associated with clinical reactivity. LIPV4 is a sarcoplasmic calcium-binding protein, and they said it's not very common to be positive, but if it is, then there's a high likelihood of a positive challenge with that. And then your arginine kinase and the hemocyanin, that is what's cross-reactive with your dust mites and your cockroaches. And so if you're very dust mite allergic or cockroach allergic, you might show up to a positive shrimp because of that. And then the last one is wheat, and so there's about 50% resolution by age 7. Wheat IgE has a poor predictive value, and they said that a lot of it will indicate actually just cross-reactivity with grass. And so your major proteins are your glutens and your gluten, are in the gluten family. So you either have gliadins or glutenins. So the triaglidin, so that's what's indicated in a primary wheat allergy, and it has low pollen cross-reactivity. And then kind of a subset of that is the omega-5 gliadin, or Tri-A19, and that's one of the seed storage proteins. And again, it's associated with a primary wheat allergy and immediate reactions in children, and it also has a role, so a lot of times this is what's going to be checked in wheat-dependent exercise-induced anaphylaxis. And so this is a summary slide. There was a kind of pro-con debate in using component testing in the Annals that was actually published earlier this year. And so this is in the pro paper, but it kind of goes through, again, all of the major allergens that I just talked about and kind of which ones are, indicated as the best predictors of clinical allergy. It also kind of, which I did not talk about here, but I also talked about the venom allergies, grass allergy, and then pet allergies and all the different dog ones. And actually, I had a board question about one of the dog allergens and cross-reactivity with it. And then this is kind of, so it's from a different paper looking at component testing. And so it has some general cutoffs. As you can see, it's hard because, a lot of these are very variable. For example, your ARA-H2, it gives you a range of 0.35 to 42. And so that's pretty big for your 90 to 95% positive predictive value. Some of them are very small. So for like the ANA03 and your berry 1 and jugar 1, like it gives pretty low for these positive predictive values. But I'll kind of, flipping gears a little bit to kind of play devil's advocate, there in the flip paper, there was a pro paper and then there was a con paper about using diagnostics. And so, part of the issue with this, I think people are really excited because they want to find, I think a lot of families come in and they're like, what are my chances of having a food allergy? What's going to happen? And you can't really tell them anything aside from being like, your testing's really positive. I think if we were to feed you, you would have a reaction, but no one's actually going to feed that child in clinic just due to, risks of having a reaction. And so a lot of these studies, they're kind of there's a lot of patient selection bias because you're choosing patients that are already, that they're allergic to the food. And so then you're kind of just trying to look through their blood and see what do they have in common and what things are positive and what things are not positive. And so a lot of them, again, are like retrospective studies or they're bank samples. It's unclear what the reference standard is for a lot of them. And then again, determining those positive and negative predictive values varies a lot by population and what kind of like the centers where you're at. Is it a single center? Is it a multi-center? The European studies look different than the Asian studies, look different than the like North American studies. And so there's a lot of kind of variability within that. And then again, there's still no ability to infer any kind of reaction severity or what will happen if you eat the food. And so, I came from academics where, I feel like money is like, no one really thinks about it. It's not really an issue because nothing really, it's just kind of like, you can just like do whatever you want. So I feel like you never really think about it, more so you do in the real world. And so just to put it a little in perspective, so the skin prick testing, this is just from our NAC, we charge about $14 per skin prick test. Specific IgEs, I actually called and tried to get some ideas from the different labs. So Seattle Children's about $40 per specific IgE, including then casein and ovomucoid because they run all those in-house. If you do a peanut component panel or any of the other NEP panels, it's going to be about $261 because those are actually sent out to Mayo Clinic. Quest was surprisingly a lot cheaper than I thought. So the peanut with reflex components, and I like verified this multiple times. Whoever I talked to said it was $32 to do that with the reflex. The tree nut allergy, which has all of the tree nuts with the reflex if they're positive, was about $130, and that they said that was the case regardless if you were, however many reflexed. I don't know if that's true or not. And then there's just a general food allergy panel, which we do not order, but just to put it in perspective on how many things you can get for that price, it's about $489. And then for LabCorp, the allergen profile was about so it kind of looked at the tree nuts along with some of the other foods, and then that was about $703. And if there were any positives that refluxed, it depended about $42 to $252 per test. And then kind of looking at just a single allergen, so I just chose egg white from their menu. They said it was about $37, so that's pretty comparable to what Seattle Children's charges as well. So kind of with all of that, what do you do? And so a lot of it is assessing your pretest probability. If you have a high probability that it sounds like the kid had a, clinical reaction. It doesn't really matter what test you choose in regard to just skin prick testing or specific IgE. Really, your goal is to confirm sensitization and just kind of then, monitor it from there. If you have a low probability, so you have either like an unclear situation, where it's unclear what the ingestion history was, or they're like distantly from that, then you could potentially consider a stepwise approach. And in that pro-con paper by Matt Greenhot, he kind of said, the whole goal of these component testing is, you want to rule out, there's a chance with these tests that you're going to have some likelihood of a potentially false positive result. And if you have a false positive, then, that's causing people to avoid a food that they don't need to avoid. And he said, ultimately a highly specific test could significantly reduce the likelihood of a false positive. And then those that tend to be more risk averse with respect to food challenges, then you will potentially kind of eliminate the need to perform that confirmatory procedure. And then interestingly, he said, if it's a false positive, you're causing a kid to avoid something that they don't need to avoid. If it's false negative, he was kind of like, well, sooner or later it'll pan out. Like if it's a false negative and they'll get exposed to it and they'll react, and then you'll kind of know, well, that's probably not the case. And so looking at this stepwise approach, and so there was a paper that looked at, it was 100 kids that were peanut allergic and 100 kids that had peanut sensitization. And so they compared different strategies for diagnosing this peanut allergy in the kids. And there was about, the median age was about 14 months. And so if you were looking at just specific IgEs and using that as your kind of threshold greater than 15 or less than 0.35, then you would need to do 95 confirmatory OFCs. If you were just looking at skin prick testing alone, then that was about 50. And if you were just looking at ARH2, you'd get about 44. But then when you kind of did a stepwise approach, combining the specific IgE with the ARH2, that got you down to 32 OFCs, and then skin prick testing plus ARH2 got you down to 21 OFCs. So that really kind of helps you narrow down who you should and shouldn't challenge. And then just a small quick note on oral food challenges. You know, we say that you should offer them when the odds of tolerating the food based on the history and other tests are reasonable for the circumstances. Looking kind of overall, there's about, usually they say about a 50% pass rate for clinic OFCs. And interestingly though, a lot of families decline OFCs. So either they're scared about the procedure, they're scared, they don't understand what it means if they pass or fail an OFC. And then I have seen this a lot in fellowship. Despite passing an OFC, then a lot of families will not include the food in the diet. And then I've seen it come back where, you know, we did a peanut leak trial, they passed, they did great, and then they didn't include peanut in their diet, and then they came back like a couple months later and had actually reacted to peanut. So kind of, you know, then emphasizing why we do this and, you know, why it's important to keep stuff at least for that immediate time in your diet. And then quality of life is, per the studies that they've done, have showed that it actually improves post-challenge, even when the procedure results in an allergic reaction. And so kind of in conclusion, so the top statement is from, again, the practice parameters back in 2014, the updated ones that were practiced, and it says the CRD is a promising new diagnostic tool in the field of allergy. However, further investigation is warranted. It's not routinely recommended for the diagnosis of food allergy, but it might be useful in certain clinical scenarios. And kind of so breaking those down, kind of some of the more useful clinical scenarios that have been outlined in some of the review papers that I was going through. So, you know, to help determine transient versus persistent food allergy, so potentially using it for your baked milk or baked egg and see if those levels are low, then are they going to be able to outgrow it, versus if they're higher, then maybe that's someone that won't outgrow those. If your skin and your serum allergen tests are discrepant and you kind of need that third number to kind of help push you in one direction or another, I think, and then to determine clinical reactivity, when a patient is sensitized without a history of clinical reaction, and skin and serum tests are positive, but the patient may be tolerant, and so kind of your only available option would be to do a food challenge, and it can kind of help you see, like, would it be worthwhile to challenge them or not. Those last two were kind of in that con debate, as kind of, you know, even though it was a con against doing component testing, those were kind of the two main ones that were highlighted as potentially something that would be useful. And I know Dr. Brandt had a situation not too long ago that he was saying that it was a girl that had pretty big peanut skin prick testing and pretty high or relatively high specific IgE, but then her component testing was all Birch, and so she, despite that, was able to tolerate the peanut oral challenge just fine. So in kind of those situations, then it, you know, it helps them pushes you towards doing an OFC that would be safe, and then they can potentially not have to worry about that food allergy.
I think another good example is, you know, most, let's say you have a 7 or 8 millimeter egg or milk, and you're going to say, let's try baked goods, and they crump on the first quarter of the cupcake. Then I've gone to checking the components. I mean, balancing cost of doing it in every child. And then that becomes something that I'll follow over time, if it's ovomucoid or casing. Very useful.
Sarah, what are your thoughts about fresh food skin testing?
So I actually looked this up because I was very torn about it. So it's interesting. So, you know, there are some papers to support that in certain foods it's better. And so I didn't, you know, look at it specifically for this, but it does say for certain ones that it is more like sensitive and specific, but I haven't looked into it too much more. All I know is I've only ever done extract testing aside from fish and shellfish, which the extracts are just not very good, and so I usually do fresh for those. But I, again, practice how people before me have practiced, and that's what they did. And so I feel like I'm starting to learn to think more on my own and not just do what my attendees want me to do or their style of practice that you have to cater to.
I'm curious if you came across anything that sort of perplexing high false positive and high false negative things for soy.
So I didn't, like, so I knew for pretty much all of the foods, you know, in all the review papers and stuff, there was very big caveats in saying, even though everything is negative, like you can still have a clinical reaction. And then there's definitely examples of people having, like in all of the various, you know, I think for all the papers when they're publishing, like this is like the component that you should use, or this is the one we should test. Obviously it's kind of a biased and a subsampled population, so they want it, you know, I think a lot of it is fitting within that mold, but they've definitely had, there's papers for peanut, like of RH2, like greater than 100, and then they're able, like there's some, like some people are just able to tolerate it, and it's hard because we don't just go around testing everyone that can tolerate. I think that's kind of the problem with some of these papers is that, you know, you're looking at people that are peanut allergic and then you're kind of sifting it out and what's common among those. And then even if you look at people that are peanut tolerant, a lot of times unless they are sensitized, then you also don't have that component. So you need to kind of find people that are sensitized and can tolerate it. But I know that in Japan, they said the glyamate was like super useful for the Japanese children and they found significance. But in the European studies for the same thing, they like couldn't find that it was any different than just doing skin prick testing and specific Ige testing, which again, all of those are variable in how specific and sensitive they are. Yeah.
So if you have a false negative, a false positive, excuse me, it's inconvenient for the patient if they avoid the food, but it's low risk and low morbidity. But
It
if you have a
is.
false negative and then something happens, what's the data on how often that happens? If you have
It's
data.
a great question. Yeah, I didn't find anything specific on kind of how often that happens, that it's false negative. And it's hard because I think a lot of times, even if you're testing to negative, like most of the time they come in with a clinical history. So at that point, you kind of just wait it out and see if their testing turns positive. Or if it's like a baby and their testing's all negative and they've never introduced it, then you kind of always have that caveat. Well, there's, you know, a 2 or 3% chance that you might have a reaction even though this is negative. And then that again pans out with time. But I guess the food avoidance, yes, it's low risk, low morbidity, but it's still like an EpiPen and a lot of, especially I feel like as these kids become more teenagers, there's so much anxiety around food allergies and reading labels. And so if they're not truly allergic, then that might be something worthwhile to better sort out.
The other caveat I would say is I have found 80% of the time false negatives really weren't negative to begin with. So the initial premise was wrong. And I know Mary's very compulsive about this. Did the nurse really prick it? Well, so go back in and redo it, or is it a lab error?
Right.
You know, I
I've had
get
that
something
happen
that's a
too.
terrible history and it comes back, everything's negative from the lab. It's like,
Yeah,
something's
well,
not-
there have been mix-ups at
It's sort
children's
of
and
your,
stuff. I mean, I've had that happen.
Yeah.
And that's where sometimes, like, if the story's good, I mean, it's back to, it's really the history.
Yeah.
So if the story's good and like the nurse comes and says it was a negative skin test, I'm like, that's when I sometimes will say, go put the fresh one on and then it'll be huge. And I'm like, I think it has nothing to do with it being fresh. I think it's that the nurse didn't poke it the first time. So it's like doing it in duplicate. You know how you did penicillin in duplicate? This is how you do duplicate.
And that, I mean, and that was like kind of going off of even just that skin prick test. It's hard because, you know, you don't know what devices they're using. You know, everyone uses different devices. Everyone has a slightly different technique. And really, like, pressure can make a big difference in just a hand, like, you know, 1 or 2 millimeters, which, you know, doesn't seem like a lot. But when you're kind of deciphering positive versus negative, then that can really kind of put you in that gray area.
I have 2 areas of quicksand I'm hoping you're going to help me with. One is the new casein mutation in milk. Is A2 milk is the alpha casein mutation? And did they talk about that in any of your milk testing? And the second is there any hope in FPIs that one of these component proteins is going to save our butts in that disease?
So they were,
No.
so for the first one, I didn't see anything specific. I didn't personally look for, I was kind of just looking mostly at the reviews, which are, you know, reviewing the past several years. And so no one specifically mentioned that. in regard to that, I think that's everyone's hope is that there's going to be something, but for all these non-Ig mediated, I think it's going to be hard. But they kind of, you know, in all the stuff they talk about, you know, this is all for Ig mediated, and then we're all left for like EOE
I think
and
you can
for
help me. I just wanted to know if you could.
FPIs. Yeah, I know. Because I feel like that's weird. I was just actually asking them about like kind of FPI stuff and how people handle it with skin prick testing and.
Do you guys feel you can separate out the super high IgE eczema people from the dangerous IgE people without component testing and food challenges? Do you think they're that good?
I mean, a little bit, but I don't think it's that. I mean, I think if your IgE is really, I think that's when you need both pieces of information, because theoretically their skin, if their skin is good enough to test and it's not crazy, then that should give you a little bit more, like to use both of them together. But it, even in like the practice, it says there's no real, like, and I'd asked this at one of the like fellow at the Quad AI when there's like the fellow conferences, one of the, I can't remember who was talking, but again, they were kind of running through these different clinical scenarios where they had the skin prick test and the, like the component test and kind of, you know, the clinical history and if they challenged or didn't challenge and what the outcome was. And so I've always wondered, you know, if your IgE is like 3,000 and your stuff is kind of, maybe it's not like greater than 100, but maybe it's like 10 or 15, like is there some sort of equation or is there some way to kind of take that into account or do some ratio? And they were saying that there is not, like you kind of have to take it at
but I
face
do
value.
think in the practice parameters they say not to check.
Yeah,
the
they say
IgE,
not to check the total
but I think you
IgE.
should check the IgE because I've seen where the IgE is like 300
Yeah.
and then you look at like their egg is probably like, let's say 15, and then 2 years later you'll check the IgE and it's 1,000, and now their egg is 45, and really it tripled, and I'm just like, well, I think that's just the IgE, and it's just causing this
Right.
artificial
Yeah.
binding.
But I've always
So
tried to
I
see if
don't
there's
know,
some
you
No,
know,
formula, but
Or you
there's
get
not.
background noise. I've had
I
children
do.
actually dilute the serum and redo it,
Oh.
and by 10. And obviously, if the test drops by 98%, you know that you were dealing with background noise, right?
I have a kid who's got an Ig to peanut of 10,000, and his
Yeah.
component testing shows it's not ERA H1, 2, or 3, and he eats peanuts all the time, has terrible eczema. So the
Right.
parents keep saying, when do we have to wear it? I say, he's already eating it, so why do you care?
Don't
But I
test
don't
them.
really
That's the
have, I don't know what
Don't
to tell
test
them.
them. Don't
I mean, I
It's
feel
already
like that's
Don't
when
stop it.
who even, I guess that's
Why
like
do
where
they
you run
test
into the
them?
I
problem is
inherited
when
him as a second opinion,
Yeah.
so I
but that's the hard thing, because then like,
said,
I
keep
feel like
eating peanuts.
that's the thing with like, you know, your
Well, tell them to
clinical
stop
history
and
to
then
begin
pull
with.
in.
Yeah.
Send them to you.
We don't want them.
Drink A2 milk, you go to Mary Liz. That's a good plan.
One of the issues with the false positive, I think, is that, you know, pre-masticated food, and the mothers who would chew their food first and give it to the baby, part of the salivary digestive enzymes break down the protein a little bit. So you get that discrepancy too. That putting something in the mouth and chewing and
I've never
saliva.
had that many moms say that
You should
they're
try
like
that.
baby birding their food.
The bird technique. You know, for us old guys in the room, which probably means me and Nick and Mike, there was a guy who used to come to the allergy meetings each year who only anaphylexed to cooked fish.
Yeah.
And when you tested him for raw fish, he had nothing. Then you cooked it, and the guy would literally try and die instantly. And it was a conformational change in the protein that actually
Right.
figured it out.
Right.
But none of our tests look at cooked protein; they only look at
Yeah.
raw
Yeah,
protein.
that's
Well,
another.
that's
So this was another
lentils
false
are, I mean,
positive.
you don't need
Yeah.
raw lentils really,
Well,
but
I mean,
lentils are
anyway.
another good example of a
Yeah.
lipid transfer protein that gets opened up when you cook it.
Yeah.
So you have the parents bring in the actual food, the way they prepare it, and actually test for that.
And lentils was actually one of the ones too that they kind of cited along with birch and like birch and then the cockroach like cross reactivity, that like the proteins themselves are very similar, and so you can test positive to a lot of the different like beans and lentils, but then clinically you might only react to one or two, so there's like something in there that's slightly different, even though there's a lot of cross reactivity among all of those.
So Len's up in Hawaii,
Sexy, you and not me. I'm
and
offended.
he wants to know who, yes, he should be.
Leonard,
Who in the audience does component testing into which foods?
What?
Who
He
does
wants,
component?
yeah, who in the audience?
Peanut.
Yeah, I do
Yeah.
peanut.
Peanut.
Yeah.
Casey and I do
And I
all
do
mucoid.
casein and
Yeah.
ovomucoid.
And peanut.
By far.
I see mainly adults, so I usually don't, but I do run peanut for them.
And
Well,
eggs
actually, I
are
just saw a
safe.
family that they insisted on doing that. The mom had been reading a lot, and so she wanted component testing for every single nut.
Ooh.
So, like for the walnut, I mean, the kid is like, she's like 15 and or 16, she's going off to college soon, and mom just wants to know, do they need to keep still avoiding it? Plus, she's pretty birch pollen allergic, so, but I don't normally order those.
Yeah.
I had LabCorp order those for me for like free or not free because I like wrote just the like nut IgE and then they like reflexed all the components and I was like, I don't think I ordered this, but
Yeah.
they did it all inclusive. But yeah, we used to do it in fellowship. We started doing more we have a lot of really bad cashew reactions. And so we did it more we started doing the NO3 and just kind of looking. I think part of it was just, also just academic like curiosity and seeing like, could we filter out these kids that were, their skin prick test was pretty much negative. Their specific IgE was very unrevealing, very low. And then these kids, you give them a spec and then they become like hypotensive and have something going on. And so for these like, more severe ones, which I feel like cashew is just weird, we started just looking, but we didn't have a lot of data by the time I left to see if those kind of panned out a little bit more.
And Sarah Lynn has a really simple question. What's the mechanism of sensitization but not clinical reactivity?
Why is there air? Simple answer.
I mean, you're also like you're sensitized to your skin. You're sensitized to a lot of. I don't think we have some people are just more allergic than others. I don't know if we have a good reason why like, some people become sensitized and then don't push to tolerance versus others. I think the skin versus oral is a big one now. Like looking at these kids that have eczema and they have like peanut protein like in the dust and that's sensitizing you to your skin, and unless you introduce it early enough, then I don't know.
Yeah.
The same as the rest of the food allergy literature.
Sarah, or the group, I was just wondering, in terms of the dust mite and shellfish cross-reactivity, I know it's kind of controversial if, like, in addition to having sensitization, is it kind of cause like oral allergic symptoms? What's everybody's opinion or experience?
Yeah.
I usually stay away. I don't know. I feel like we used to, like, if your shrimp was high, like, we didn't usually do components for shrimp, but, like, if it was high, we kind of always just steered clear because the predictive values are so low. But it's hard because I feel like if you're not tolerating, like, I feel like a lot, like, you're coming in, I feel like shrimp in particular, like, people usually have some sort of shellfish need.
I think in
Right.
adult patients that I see, often you see patients who are like, well, I have some itch in the back of the
Yeah.
neck. And I'm like, well, it's
Right.
probably okay. And
Yeah,
then they
that's
are,
true.
have a small positive to
Or
bolus
or
and
it
then,
varies
yeah.
from time to time.
Yeah.
Like maybe degree of cooking, or I need 42 shrimp, or, that sort of thing.
Yeah.
It's interesting because this came up in a patient the other day that they know Fedia no longer does shrimp components, but they actually do DERP10, which is a tropomyosin-related thing for dust mites. And that, again, may or may not correlate with relative risk. But, the obvious question, often these patients are, oh, I love eating shrimp, I want to eat it. So we'll do a challenge maybe, but give them a proxy for, well, you look okay with 6. If you have 10, call them.
12.